All right, folks, 12:03, and might as well get started. So I'm Sasha Binder, adult respirologist from the Centenary site. It is always a privilege to speak to the entire department and to share what is a passion of mine, which is the medical education and specifically continuing medical education. If you enjoy these presentations, well, good fortune for us because I have two more talks scheduled for January and March of next year on COPD in January and asthma biologics in March. Just by way of disclosures, I do speak on behalf of essentially every pharmaceutical company in respiratory medicine in the country, as well as advise and consult at a national and international level. I just will say that my laptop today is a bit glitchy. So if for some reason I stop speaking, give me 30 seconds to reboot and I will be back. So fear not. I'm still on this planet, just not connected to Zoom anymore. I'm going to start with COPD. And I mentioned that there'll be a little bit of COPD, and it truly is just 5 minutes on COPD. Look, I've had the privilege recently over the course of the summer to work with my colleague Walter, family physician out of Victoria, BC, creating a new curriculum for CME education for primary care across the country. And we've actually broken it down into individual regions of the country, targeting reasons for, well, the barriers behind good COPD care and targeting to a local approach to target barriers that exist in one part of the country that may not be a barrier in another part of the country. But if I could summarize this, the key message with respecting to take away from COPD is that it is a condition associated with increased morbidity and mortality. There are a few main drivers of this, but the key that we will discuss today and the key behind pharmacologic therapy are exacerbations. Exacerbations are trajectory altering events in the life of a patient with COPD that have a negative impact on lung function. Exacerbation of COPD to the lung is no different than a myocardial infarction to the heart. What is lost tends to be lost forever. And the primary symptom that patients experience, the patient's driving morbidity, is dyspnea. It is a fundamental limitation of what they're able to do, how far they're able to go, what daily life looks like. It leads to exertional intolerance. It leads to a sedentary lifestyle. It leads to physiological deconditioning and a decline. Lose your physical and functional status, have a decline of lung function, and that is a perfect setup for a bad outcome, which is increasing risk of future exacerbations. Exacerbations are those trajectory altering events, but hospitalization and severe exacerbations requiring hospitalization further still are mortality driving events. Outpatient exacerbations increase mortality, inpatient exacerbations more so than outpatients. And of course, that has a negative impact on overall health status, how you bounce back from that, because you'll never bounce back as high as you were before, adverse cardiac events, and increased risk of mortality. In Ontario, if you are 65 and older and admitted to hospital with a severe exacerbation of COPD, and that is the definition of severe exacerbation. If your exacerbation takes place in an emergency department, hospital ward, or ICU, it is lumped together as a severe exacerbation of COPD. Your 1 year statistical mortality risk is 27%. 27% of patients will die within 1 year of having a severe exacerbation. In this case, their first exacerbation. If you manage a patient with a severe exacerbation of COPD in the emergency department or hospital ward, this is a key moment for your friendly neighborhood respirologist to be a consultant and co-manager of that case. If that patient does not have an outpatient respiratory specialist, my comment to my colleagues is that the consultant should become that outpatient specialist. And if they do, then they already have a connection as an outpatient to carry that baton of care. But the hospital is a key moment to alter that trajectory of mortality risk and to implement optimal pharmacologic therapy. Our 2023 guideline for pharmacotherapy in COPD makes it very simple and straightforward as to what we should do to optimize these patients. There are only two inhalers that you must remember. The figure on the left-hand side is the algorithm for pharmacotherapy in COPD across the entire spectrum of the disease, from mild to severe. I've highlighted in red where hospital-based clinicians, colleagues that I'm addressing today, will need to focus their attention. Patients who have had a severe exacerbation of COPD are considered high risk for another event in the future and increased risk of mortality. The definition technically is 2 moderate outpatient events or 1 severe event in the previous year. But by virtue of the fact that you see them in hospital, they qualify as being high risk for an acute exacerbation of COPD. There is only one inhaler category for these patients. It is prompt initiation of single inhaler triple therapy. This is irrespective of what they were on previously, if they were on no pharmacotherapy or any other form of pharmacotherapy. It is single inhaler triple therapy. You have two options, both on formulary at the Scarborough Health Network. Breztri, single inhaler triple therapy, which is a meter dose inhaler, 2 puffs twice a day, or Trelegy 100, dry powder inhaler, which is 1 puff once a day. There is no role for ICS-LABA only therapy anymore in COPD. So if someone is on Zenhale, Symbicort, Brio, Advair, and not on a LAMA, they're missing a fundamental category of drug to prevent exacerbations. And we do not recommend open triple therapy, meaning 2 inhalers to arrive at triple therapy. We recommend a single device. There's a reason that we're having this discussion about prompt initiation in hospital. The data demonstrates that if we have prompt initiation of triple therapy within 30 days of exacerbation, and there's additional data that I won't show, showing a signal if it's established within 14 days, you reduce the risk of re-exacerbation and repeat event, be it moderate or severe exacerbation, inpatient or outpatient, or severe exacerbation, just inpatient. Prompt initiation matters. Strike while the iron is hot. And specifically here, we're looking at single inhaler triple therapy being implemented promptly. At the end of the day, I would much rather a patient start on appropriate guideline recommended therapy in hospital, have a chance for myself, the MRP, the nurse, and the pharmacist to counsel and educate, optimize therapy, and start recommended lifelong therapy for management of COPD in hospital, because anything less than that increases their likelihood of bouncing back to hospital, which is a big challenge for our healthcare system and healthcare systems across the country. Remember that exacerbations of COPD are the second leading cause of hospitalization in Canada after childbirth, after propagation of our very species. So for this reason, if you're seeing a patient with an exacerbation of COPD in hospital, single inhaler triple therapy with LAMA, LABA, ICS, you have two options: meter dose inhaler, Breztri, 2 puffs twice a day, or single inhaler triple therapy, Trelegy 100, 1 puff once a day. Your friendly neighborhood respirologist should be consulted, and if they do not have a respirologist, the consultant becomes the outpatient specialist. If they do, they can of course see the outpatient specialist again. You'll have more on COPD in January, but let's switch gears. Let's talk about RSV. And this is why we're here today, and it's germane at this time of year to discuss this, which is a surging viral respiratory tract infection as we're now approaching peak RSV season. I'm going to break this down into 4 sections. We'll look at the epidemiology and burden of disease of RSV in older adults. I'll discuss the vaccine development because we have 2 vaccine options, and I will contrast and compare the differences between the vaccines and the clinical trials. We'll look at the evidence for vaccination in older adults and some strategies on how we can implement this in our practice. I have the privilege of sitting on a national scientific planning committee with a number of esteemed colleagues from around the country. It's very nice meeting colleagues from around the country and discussing practice challenges in local areas, and then taking that and applying this to national CME program. We were actually very fortunate. Last year, we had engagement with over 10,000 healthcare professionals within the matter of just a couple of months after the launch of RSV, and we're trying to translate that into at least double this year of reaching many individuals at the level of primary care, specialty care, and pharmacy to promote vaccination. I'm going to start with a myth that is partially true. You might think that RSV is a disease that affects kids. It's true, but it doesn't tell the full picture. We do see a high mortality burden from RSV in older adults. This is Ontario data. And when we look at Ontario data, 70% of RSV attributed hospitalizations are in children under the age of 5. It's not untrue that this is a pediatric condition. And about 22% of RSV hospitalizations are in those over the age of 65. But mortality tells a bit of a different story. Very fortunate for all of us that 999 of those 1,000 kids under the age of 5 who have not had a chance to live out life's innings, 999 of the 1,000 will leave hospital and will survive. 1 in 1,000 hospitalized will die, but the sizable majority, nearly all, will survive. It is a very different story for someone over the age of 65. When we look at 30-day all-cause mortality, 85% of RSV-related deaths of all-cause mortality are in those over the age of 65. 1 in 9 adults over 65 hospitalized with RSV will die within 30 days. Last fall, around Thanksgiving, as we were having discussions with my father, my in-laws, other relatives, friends, and well-wishers, I was that person at the party sharing these grim statistics, right? I mean, I'm great at dinner parties, but I was the person sharing these grim statistics because everyone that I was speaking to fell into this age group. And God forbid if they were hospitalized, 1 in 9 would not see the start of that next month. The mortality associated with RSV is shocking, and it afflicts those in their older years, 65 and older. 1 in 9 will die within 30 days. We do not have good data on the prevalence of RSV, and I wish, as a result of the pandemic, that viral testing centers had stayed open, because it's one thing for a patient to say, I have a viral respiratory tract infection. It's another thing for them to now know which virus they have and what the prognosis and expectation would be over the next week, month, and 6 months, because it is very different. You could have rhinovirus and enterovirus and have a very relatively calm course over the next 3 days. You could have RSV or influenza or COVID, and for the next 3 to 6 months, suffer the consequences. It's only after the fact that we can tease out, it sounds like you probably had RSV, sounds like you had COVID. There's nothing that can tell you at the point of infection. And you literally roll the die. You roll the die as to which virus you will contract. We have some data in patients with COPD. Generally speaking, RSV accounts for 1 in 9 hospitalizations for COPD. In acute exacerbations, it's detected in approximately 1 in 10 infections. But let's compare it on the left-hand side to some other viruses. Rhinovirus and enterovirus in the setting of COPD was detected in about 16% of patients. RSV, around 10%, influenza, around 8%. The key takeaway here is that influenza and RSV are just as likely statistically to affect a patient. Broadly speaking, 1 in 10 viruses during cold weather season is influenza, and 1 in 10 viruses are RSV. You don't get to choose which virus affects you. And the likelihood of being affected by the flu and being affected by RSV is similar. So if the patient says to you, I always get my flu shot, it is important for you to not let that go, but to take the opportunity to say, there is something that is just as likely, and I'll show you, actually more deadly than influenza that you should be aware of, and that is RSV. What time of year does this start? Well, it depends. On the right-hand side, I will say that RSV is highly contagious. If you look at the replication factor, it is as infectious in some studies or more infectious than influenza and COVID. On the bottom right, I've reiterated this again in the previous slide, the true incidence and prevalence is not known. But where these viruses start and finish in terms of their season is different. This is September 2023 to April 2024 data. You can see that COVID does not respect seasonality. It does its own thing. And in terms of test positivity on the y-axis, COVID runs rampant year-round. RSV in blue starts in September when kids go back to school. They go back to school, they share many things, they share viral infections, and it starts to spread in packed classrooms. RSV season starts in September. You can see that it peaks in December and into early January. It's a smeared peak. But look at influenza in gold. Influenza A in gold really takes off Halloween, early November. It then hits a peak that peaks in January and then slowly settles as we approach Easter. Last year, influenza B peaked around Easter. RSV season unfortunately started Labor Day weekend. RSV season is going to peak in December. Influenza season starts after RSV season and it peaks later. If your only opportunity to talk about RSV vaccination is when you talk about influenza vaccination, take the chance and take the opportunity and talk about both at the same time. But realistically, we're already in the midst of RSV season and it's only going to get worse as this season goes on. They start at different times, however. And oftentimes, by the time the patient is interested in getting their flu shot in November, we're actually coming to the peak of RSV season. When we look at complications of RSV versus influenza, on the bottom, on the x-axis, the farther you are to the right, the greater the likelihood that RSV is more severe. Looking at morbidity and mortality in adults hospitalized with RSV, increased likelihood of length of stay, increased likelihood of ICU admission, mortality, and secondary bacterial infection with pneumonia if you're affected with RSV compared to influenza. Greater degree of morbidity and mortality with RSV compared to influenza. So if the patient says, I worry about the flu, let me tell you something that you may not be aware of. There's another virus called RSV that is actually likely more deadly than the flu that you're already worried about. We've seen more RSV than we realize. And like before the pandemic, we had a swab that would tell us if it was flu or not flu. We then, at time of year, had a swab that would tell us a lot more, but we really didn't have anything to do for that. We couldn't really do anything with respect to treatment with that swab result. We couldn't do anything with respect to prevention, knowing that swab result. There was a misconception that RSV in adults is mild and manageable. I think I have that 1 in 9 mortality risk Ontario data, which is shocking. Under recognition due to lack of routine screening and laboratory diagnosis. Misdiagnosis, right? So sometimes we simply call this a very bad flu. I mean, it went on for 6 months of suffering, and it's probably a very bad flu. In actuality, it was probably another virus entirely. And of course, if we don't have effective treatment, sometimes we don't really do anything about it. Remember diastolic dysfunction before we had good oral pharmacotherapy for diastolic dysfunction? Kind of like that. If we don't have anything to do for it, sometimes we don't necessarily do much about it. It's wrong, I know, but sometimes this is how medicine goes. Let's try to change that. But let me add in another layer. Like it or not, age is the leading driver for increased risk of fatal and non-fatal complications from RSV and vaccine-preventable viral infections. So every year when you have that extra candle on the birthday cake, it is a marker of another year older. Yes, another drop-down box on an online questionnaire as to which age bracket you may fit into, but it is a marker that your immune system is not able to do what it was able to do last year. There is a decline in immune function. You can do everything you want, eat right, exercise, buy all of the Peloton equipment, and do everything you should do. We cannot change the fact that older age is a major driver. If we were talking about shingles and reactivation of herpes zoster, we see an increase in the age 40 bracket. It really takes off in the age 50 bracket, and it just keeps going. And that is a marker of immune dysfunction. Let's add on to older age other independent risk factors. And here we're just talking about chronic medical conditions. Pick your organ of interest, make that organ dysfunctional, and dysfunctional organ leads to increased risk of fatal and non-fatal complications from viral infections. Add on to that weakened immune status due to disease or therapy, things that we do to patients, such as chemotherapy, biologic therapy, or the impact of bone marrow transplantation, or viral-induced immunodysfunction in the setting of HIV positivity. And add on to that another factor, long-term care home, which is a reflection of patients with a rather homogeneous age group and relative stay of comorbidities in a densely packed environment in which, unfortunately, viral infections spread quite quickly. In Scarborough, we can add socialized housing as well, which has a similar degree of density, perhaps a more heterogeneous patient population, but similar degree of density, and frailty overall. Each and every one of the factors listed here is an independent risk factor. Other additional risk factors with respect to specific cardiometabolic and respiratory conditions increase the likelihood of hospitalization. This is a New York study looking at patients without a comorbidity with a risk ratio of 1. And if we look at individuals with asthma, diabetes, coronary artery disease, CHF, or COPD, the incident rate ratio of likelihood of hospitalization increases dramatically. The more items on your past medical history, the more medications you take to manage a chronic disease, the greater the likelihood that a viral infection will lead to hospitalization. When we look at hospitalized adults in Canada, practically all had a comorbidity of interest, cardiac, respiratory, or metabolic. And it doesn't just end there with respect to hospitalization. The data demonstrates that nearly 25% of hospitalized adults with RSV will experience an acute cardiac event. And that is a fatal or non-fatal ischemic, arrhythmic, or mechanical adverse event. Hospital admission for acute MI is threefold higher in the first 7 days after RSV infection. And there's a 43% mortality at 1 year following RSV hospitalization with concomitant acute exacerbation of heart failure. And that was based on clinical and biochemical BNP related criteria. I had already mentioned this earlier, that its prevalence is about 1 in 10 with respect to acute exacerbations of COPD. So community prevalence during cold weather season is approximately 1 in 10, similar to that of influenza. It's not as if on the right-hand side, chronic conditions mean that you're more likely to inhale a particle of RSV. And it's not like an RSV particle is going to say, hey, you look pretty frail. I'm going to head in your direction so that you inhale me as opposed to this other guy. It's just that when you have chronic conditions, you're more susceptible to the negative impact of a viral infection, which increases the burden of disease, leading to complications and stepwise deterioration of each and every one of your underlying chronic conditions. What if you survive hospitalization and 6 months down the road, we look at function, morbidity? Well, if we take high-risk individuals with chronic cardiac, respiratory, or metabolic disease, or we take non-high-risk individuals, so individuals without those comorbidities, a substantial proportion continue to have dyspnea and cough at 6 months. What is shocking is that myocardial infarction percentage-wise seems to be rather low, but compared to, for example, pneumonia, where non-high-risk individuals have a dramatically low likelihood of pneumonia compared to high-risk individuals, MI still remains relatively high compared to the high-risk group in the non-high-risk group. These patients have substantial residual morbidity. A New York State cohort showed that 1 in 3 adults 6 months after hospitalization for RSV had a lower functional status. And what is heartbreaking is that 8% lost their independence. For older adults, being able to live and age at home in what they call home is a high priority, a priority that they will place over many other priorities. And to lose home, to home not be what you used to call it, what it used to be, that is heartbreaking. Remember, many patients build their entire lives in where they live. Their home is a reflection of the journey that they've been on. And when that journey changes such that that destination is changed to another, that often heralds a loss of life. And we see this, unfortunately, in clinical practice more often than we would like. The key points here is that this is not just a kid's disease. 1 in 9 adults over 65 who are hospitalized in Ontario will die within 30 days. It is highly contagious. At best, outcomes are similar to that of influenza. Unfortunately, very likely they will be worse compared to influenza. Age, comorbidities, and other factors put you at high risk of poor outcomes, and add underlying comorbidities, and they will likely be worse after RSV exposure. So, what can we do about it? We have vaccines. I'm very pleased to say that we have a vaccine preventable cause of hospitalization, morbidity, and mortality of all of the things that I have just discussed. We have a mechanism of preventing that. And we have 2 vaccines to discuss. But before we discuss what makes a good vaccine for older adults, we need to lay this out as the foundation. First of all, we have to recognize that immunogenicity must be considered in the context of an aging immune system. These are older adults, and the vaccine needs to be potent to stimulate the immune response. You need the right antigenic target. The vaccines I'm discussing took about 3 decades of basic bench science to come to fruition. I could have a 1-hour presentation just about the science of the antigenic target. If you would like that, send me an email. I'm happy to do it, but sparing you that detail today. But when we're looking at novel strategies for older adults, it is about higher antigenic content and also the adjuvant that stimulates a weakened immune system with age to build an immune response and have durable, long-lasting immunity. We have two vaccines. They have not been compared head-to-head. There is RSV, which is an intramuscular vaccine made by GSK, approved by Health Canada in August of 2023. And there is Abrysvo, an intramuscular vaccine created by Pfizer, improved by Health Canada in December of 2023. Key difference: RSV is an adjuvant vaccine. It has a protein targeting the RSV fusion glycoprotein, and it has an adjuvant that stimulates the immune response. Abrysvo has the protein, but it does not have an adjuvant to stimulate the immune response. This adjuvant in RSV and adjuvant in Abrysvo will be discussed further as we look at the efficacy of these vaccines. So, clinical evidence in older adults. This is the RSV clinical trial, and I highlight this not to confuse and to add more detail into your lives, but to make some key points as to the study design. 25,000 patients randomized in 2021, 12,000 and change in placebo, 12,000 received a RSV vaccine. After the first year, placebo continued. The people who received RSV in that vaccine in the first year were randomized 1-to-1 again, and half of them got a booster dose. The other half remain with one vaccine dose at the start of the study. This is a 5-year study, so we will have 5 years of efficacy data and 5 years following these 25,000 patients to see if a booster is required. When we look at RSV, the season 1 data demonstrated that overall, the primary outcome, preventing RSV lower respiratory tract disease, was prevented with 83% vaccine efficacy. What you and I are interested in, which is how does this have an impact on those with comorbidities? In those with a comorbidity of interest, it was 95% effective. In those with severe hospitalized RSV, because remember, if you're hospitalized with RSV and over 65, 1 in 9 will die within 30 days. Well, against severe hospitalized RSV was 94% effective at preventing hospitalized RSV. After 2 years, 24 months of follow-up, overall, the primary outcome, 73% effective, and it remained 79% effective against severe disease. This is huge, preventing hospitalization. There was no recommended booster at the 2-year mark. Just yesterday, as presented at the CHEST conference in Boston, we have year 3 data. I'm very happy to report for the first time that after 3 years of RSV vaccination, remember, single dose given 3 years ago, it is 63% effective at RSV disease. It is 67% effective at severe RSV infection prevention. It is 70% effective against medically attended RSV disease. So that might involve urgent care, hospital visit, but not necessarily admission to hospital. This efficacy data remains strong, and we have 3 years worth of data for a single dose of RSV vaccination preventing RSV disease, specifically severe disease. 0 cases of Guillain-Barré or acute disseminated encephalomyelitis over the course of these 3 years. Acceptable safety profile, similar compared to prior. When we're looking at age 50 to 59, the age 50 to 59 group has been studied, and the vaccine is just as effective from an immunogenicity perspective as in those age 60 and older. RSV in Canada has yet to have the Health Canada indication for age 50 to 59. It is off-label, but it is not contraindicated, and it has been submitted for Health Canada approval. It is pending. It is approved in the United States for age 50 to 59. So some of my patients whose FEV1 is less than their age with advanced end-stage COPD referred for lung transplantation under the age of 60, I am recommending RSV vaccination in addition to Prevnar 20, influenza, as well as COVID-19 booster. It is off-label, but it is not contraindicated. And we do many things with good intentions and good outcomes that are off-label. Hopefully soon we'll have a Health Canada approval for age 50 to 59 as well. This is Abrysvo. Abrysvo was approved in December of 2023 by Health Canada, and it is the Pfizer non-adjuvanted vaccine against RSV. They took 34,000 patients and randomized them 1-to-1 in 2021. It is, however, a 2-year study. So if the question comes from you, do I need a booster for RSV? I can tell you that now for 3 years of data, you do not need a booster. And I'll be able to tell you in 2026, after 5 years, if a booster is required. For Abrysvo, the trial is a 2-year trial. I will not be able to give you data as to whether a booster is required beyond those 2 years. We just don't know. The vaccine efficacy showed 67% prevention overall of RSV infection with at least 2 signs or symptoms, 85% efficacy with at least 3 signs or symptoms, demonstrated efficacy for 16 months, not the full 24 months is what I can share today. There is no recommendation for a booster at this time. I do want to point out something in the bottom left, however. Abrysvo, which is the Pfizer vaccine against RSV, the clinical trial called Renoir did not have a sufficient number of cases of severe RSV requiring hospitalization to comment on the efficacy of Abrysvo at preventing severe hospitalized RSV. We do see that it prevents RSV infection in general, but I cannot comment as to whether Abrysvo will prevent severe hospitalized RSV. The key points for Abrysvo is that it is a protein subunit vaccine. It is not adjuvanted. It has efficacy data for year 1 and year 2, but I cannot comment on whether it can prevent severe lower respiratory tract disease. It is well tolerated. Like RSV, most patients will have a bit of a sore deltoid for a day or two. They may have some mild myalgia, chills, fatigue, fever. My father commented that he was only able to really do ironing with his right arm the day after he had his RSV vaccination, but he was playing golf 2 days later, and swing was not dramatically affected. Perhaps his score was, but not the swing. RSV is a protein subunit adjuvanted vaccine, which again addresses the needs of individuals with an older population and a weakened immune system. Excellent efficacy overall, and efficacy of preventing severe exacerbations, and we have that data of vaccine preventable severe exacerbations and hospitalization. Sustained protection over 3 years for RSV, and we will have data by 2026 of 5-year outcomes. Our recommendations for vaccinations matter. When we look at recommendations and discussions, this is the meat of the matter, sharing with patients our recommendation and our guidance for vaccination. I'm going to start by sharing what our guidelines committees and global societies recommend. Now, as you know, many of these societies are late. The clinical trials are published. A group of people dissect and digest those clinical trials and summarize it at a recommendation. That takes time. Generally, there's a Congress involved, there are various meetings, there's a Delphi consensus, and we're looking at a few years. Reassuringly, from an RSV perspective, it's 2024, and the global COPD guidelines with GOLD, global asthma guidelines with GINA, the ADA guidelines from the United States for diabetes, the CTS-AMMI joint message have all talked about influenza, COVID, pneumococcal, and now RSV vaccination. We also have recommendations from NACI, the National Immunization Statement, American recommendations from ACIP, from the CDC, and from Quebec. And I'll share NACI and CDC. The Health Canada label for RSV and Abrysvo is all adults over the age of 60. The clinical trials involved community-dwelling adults over the age of 60. 60% of patients in the trial were free of comorbidity. What the trials looked at are community dwelling adults. So if you've got a patient in front of you, 60 and older, living in the community, free of comorbidity, and you're asking yourself, would this patient have been studied in a RSV and a RSV clinical trial? The answer is yes. That was the patient. NACI and ACIP make recommendations for vaccination that then leads payers to fund those recommended vaccines. You'll see a bit of a difference. NACI, in their infinite wisdom, and don't question me on that wisdom, please, has recommended that RSV vaccination is strongly recommended for all adults over the age of 75. I will comment that the clinical trial involved community dwelling seniors over the age of 60. That is the label indication. They comment that it's recommended for those particularly at risk of severe RSV disease. And I have yet to meet many 75-year-old or older patients free of comorbidity. So I would say that all of them are at increased risk. I agree with that. Adults over the age of 60 in nursing homes and other chronic healthcare facilities have a strong recommendation. And of course, that's a congregate care setting. But they have a discretionary recommendation. But this is what you and I do each day in clinical practice with each patient encounter. We discuss the risk-benefit profile with our patient, and they recommend that adults 60 to 74 consider RSV vaccination in consultation with us, those who manage their chronic conditions, those who manage them in a hospitalized setting or an outpatient clinical care area. It is recommended as a single dose. We do not have a need for booster at present. It's optimally administered now. And when I have 3-year data for Arexvy showing no booster is required, I recommend it now, but I talk about it year round. Because if you get it in the summer, it'll protect you that fall and for the next 2 falls at least. And it can be co-administered with other vaccines. The CDC recommendation is similar. Adults over the age of 75 should receive a single dose. Adults 60 to 74 at increased risk should receive the vaccine. The CDC recommendation came out first. NACI's recommendation came out second. You probably are aware of this, but our Canadian organizations, unfortunately, don't have the same budgets as our American colleagues. Some of the risk factors for severe RSV disease, chronic cardiac or pulmonary conditions, weakened immune system, other conditions that are relatively immunosuppressing, such as obesity and diabetes, and also congregate care facilities. These are in line, but it's also in line with what they suspect payers will pay for. That is why you see a recommendation difference between what was on label with Health Canada and what the body recommends, which is likely what provinces will then pay for. Again, single dose, no need for a booster at present. The best time is now, but really any time, because the data demonstrates efficacy for at least 3 years with Arexvy. The CDC goes on to list other conditions amongst those aged 60 to 74 that would increase the risk of fatal and non-fatal RSV infection. It's similar to what we've discussed earlier. Take an organ and cause it to be dysfunctional. Even asthma, the presence of coronary disease, renal disease, type 2 diabetes, hematologic conditions. The list is exhaustive and extensive. You can focus on your organ system and broadly. The comment of obesity, though, is specifically severe morbid obesity, BMI over 40, as opposed to obesity at a population level, which would be considered over 30, which is about a quarter of the population. So this would be a smaller percentage of the population, around 15% or so. You can co-administer seasonal influenza vaccine, COVID booster, pneumococcal vaccine, Tdap, Shingrix, and RSV. I had the privilege of working with a colleague in Northern Ontario who performs travel medicine and active at the level of pharmacy of supporting vaccination. And from a travel medicine perspective, he has patients that are coming to him that have to leave tomorrow. And he needs to get as many vaccines in as possible to give them as much protection as possible. And almost all of these vaccines can be co-administered. Sometimes our pharmacy colleagues prefer to not co-administer in case there's a risk of interaction. Your immune system doesn't care if multiple vaccines go through the same hole. The immune system will sort it out. There is no lack of immunogenic effect or alteration of immunogenicity with co-administration. I do recommend separating by at least an inch on the deltoid, just in case there is a reaction, you want to know which vaccine. And if you put it in the same hole, well, that's a bit of a problem. Also, older adults, the deltoid may only be big enough to support one vaccine just in terms of its size. Younger adults, you may get away with actually putting more than one into one deltoid. We need to prioritize this. And the pathway to immunization is a multidisciplinary discussion. There's an allied care component with respect to our pharmacy and allied health colleagues. There is a primary care role, but there's also a specialist role. And that's why I share this with yourselves. I share this with primary care colleagues and pharmacy colleagues across the country, that this is a multidisciplinary approach of putting it on the radar. We as specialists often do not have the means, the equipment, and the resuscitation equipment in the office in case there's a vaccine-related anaphylactic event to safely vaccinate patients in our office. But we write consult notes. We carbon copy physicians on those notes. One clinic day might involve us communicating with 30, 60, 90 colleagues, sharing our recommendation. They read our note. They may not read the middle of it, but they'll read the end of it. Put it in your note. And I'll touch on this at the end, how we can do this in the office. Identify the appropriate patients. It is adults 60 and older. Counsel and recommend vaccination. Write the prescription. I'll show you that at the end. Look at some of the barriers. The pharmacist is able to administer vaccines. The pharmacists love doing this. It's part of their expanding consultation and clinical role. They can give influenza and COVID vaccination without our involvement. They need a prescription and a direction from us for Prevnar 20 against pneumococcal and RSV vaccination. This can help facilitate administration. The number one barrier to not being vaccinated among Canadian adults is not cost. We think it's cost. If you ask physicians, we say it's cost. For patients, it is not having the recommendation by someone they trust, a healthcare professional. Patients only see cost as a barrier amongst 19% of patients. When I explain to patients that the risk of mortality is 1 in 9 in 30 days, that morbidity at 6 months affects a third of patients, that up to 10% will lose their independence, their home, the cost of the vaccine pales in comparison to the cost that they may suffer. And you roll the dice. If your patient is concerned about the flu shot because they're concerned about catching influenza, you're just as likely to catch RSV. And you won't know until 2-3 months of morbidity have gone by, hopefully not mortality, but you won't know until after the fact what you suffered with. On the right-hand side, patients commented, this is for shingles and pneumococcal, I didn't think it was necessary. Explain to them the risk of contracting it, the risk when you do contract it, and for those who've never heard of it and we didn't mention it, change that. Strong endorsement by several bodies for those 60 and older in the community, and of course, those with comorbidities. Age is the biggest number that has an impact on what we do in life. We add chronic conditions and environment to it, but those are major risk factors. Optimal timing is now. We're in RSV season. It really was in late August, but take the opportunity. Many of my patients with asthma, for example, who work in education, the only time that they can reasonably see me is in the summer, because work unfortunately means it's hard for teachers to take time off during the school year. I take the opportunity I can in the summer to get everything done because I got a whole year ahead of me that I need to prepare for. I think I have it a bit easier because as a respirologist, we have chronic respiratory conditions that have controller and reliever therapy. We discuss an action plan with patients at each visit. And what better way to prevent having to use the action plan than vaccination against respiratory tract infections? I know it may be different in your specialty with respect to incorporation. You'll probably pontificate and think about this as to how I'm going to work this into what I say. But we need to make the recommendation. The number one barrier for patients not being vaccinated is us. There are publicly funded programs across the country, and I shared this invitation today with our colleagues from cardiology and nephrology. So for those of us joining, I'm sorry I didn't give you a shout out at the start of the presentation, but heart and kidney represented as well, because Ontario government has put in place some funding. Bottom left-hand side here is Ontario. You don't have to worry about those in long-term care, retirement home, or elder care lodges. The MRPs of those facilities are well aware of vaccination against RSV. Similarly, for those experiencing homelessness in shelters, and for those identifying as First Nations, this is a well-established protocol out there, but do keep these patients in mind, because if they haven't had the discussion, you might be the first person to talk about it. Another person taking care of them as MRP will be able to vaccinate. But for our hematology oncology colleagues, solid organ or hematopoietic stem cell transplantation, for those from nephrology receiving dialysis, and anyone who is ALC, scheduled to go to TCU or a triple C patient, they are eligible for vaccination. You're probably wondering that I've talked a lot about RSV and Abrysvo, and last year, the publicly funded vaccine program was RSV, and this year it's Abrysvo. Why? Well, if you know anything about government, you know that cost is the bottom line. And for 2024, 2025, the tender for national vaccination program against RSV for older adults, the selection criteria on the bottom right-hand side was cost. At the pharmacy level, RSV and Abrysvo are similar price for the patient. The pharmacy in Canada will pay about $230 to get the vaccine. The patient will pay around $280. It is cheaper at Costco. It's about $260 at Costco. In Canada, RSV vaccine at the level of the pharmacy of $230 is the second lowest cost on the planet. Lower than us is Portugal. I think it's about $210 Canadian for a Portuguese pharmacy to buy the vaccine from the manufacturer. In the United States, the pharmacy pays the manufacturer $280 US for the vaccine. So it's still 280 Canadian dollars for the patient to get the vaccine in their arm. It is less expensive than the United States by about 50%, really, when you look at currency and the markup. And the second lowest cost is Portugal. So if you do have a patient going to Portugal for vacation over the winter, there is an option there. But for the rest, it is at the pharmacy here. Abrysvo did submit a lower price, and that is why the government selected them. I've shown you the efficacy data for RSV and Abrysvo. There is a difference. But for our patients admitted to hospital, ALC, TCU, triple C, dialysis, stem cell transplantation, homelessness, First Nations, or those in long-term care, retirement home, or elder care lodge, Abrysvo is available. Coming soon to Epic, you will have this build. It is not there yet. I understand that pharmacy is working on getting supply, and once supply is available, this will be released for use in production Epic, but it is there in the background and it will be activated once we do have supply. So check out your emails. Pharmacy will also be aware, especially the pharmacists assigned to areas of our hospital and organization where ALC, triple C, and TCU patients reside, because they will be well aware that these patients are now eligible for coverage and that this has been activated. If we're looking, and just in the last couple of minutes, if we're looking at RSV, pregnancy, and infants, and I will say that as an adult respirologist, something that I unfortunately do not see very often in my practice. But if we're looking at infants and preventing RSV, the monoclonal antibody Beyfortus is the recommended approach over vaccination of the parent to protect the infant. So the pregnant parent is not recommended to be vaccinated over Beyfortus. Beyfortus is recommended to give to the infant to prevent against RSV. It is a monoclonal antibody, and this is based on the efficacy, the duration of protection, and the safety profile. If Beyfortus cannot be given, either parent choice, availability, RSV vaccine, Abrysvo may be given to the pregnant individual if they are not able to protect the baby using Beyfortus, or they do not wish to use Beyfortus. The eligibility criteria for Beyfortus is listed below, and I can share this with a reference slide for you. When we're looking at pregnancy RSV prevention, it is to be given to pregnant individuals between 32 weeks and 36 weeks of gestational age who will deliver near the start of RSV season or during RSV season. So now, all the way until April, May. So by the time we get to Easter 2025, that's when we can pay less attention to this, but Abrysvo for pregnant individuals between 32 and 36 weeks gestational age is recommended. Folks, add vaccines to your EMR. You and I know that when something is a favorite in the EMR, it's easy to prescribe. There are fewer clicks, and of all the things that we have to do, it's easy to have that discussion. I talk about 6 vaccines with each patient over the age of 60. Of course, shingles onset is at 50, and our primary care colleagues are well versed in this. Tdap is a regular booster. Our primary care colleagues are well versed in this. Flu shot, annual COVID booster for all patients in my office. I discuss this with each visit. And then RSV and pneumococcal for the older age group. But really, it comes down to 6 vaccines for all. If you want to focus and be a little tighter, it's the flu shot, the COVID booster, RSV vaccination, and pneumococcal. Put it in your EMR. This is what it looks like. Prescribe a RexV or a Brisvo, prescribe Prevnar 20, and write in the comments, medical order, pharmacy to dispense and administer. That is all they need. The pharmacist will dispense the medication, they will administer it. Patients can get a RexV and Prevnar 20 now. In late October, when COVID booster and influenza shot are available, they can get the flu shot and the COVID booster. They'll be well protected. Inform the patient and recommend vaccination. This is key. The pharmacist can do the flu shot and the COVID booster. Primary care is well versed in shingles and Tdap, but they need to hear it from you. Please add it to your note. If you recommend it, our primary care colleagues will pay attention, and patients will too. They read our notes. Our primary care colleagues will send me, I sometimes have dictation errors, they'll send me notes back with multiple lines underlined where they've read and paid attention, and something circled with a question mark saying, what was this? And I say, oh, it was a dictation error. But they read our notes. Put it right at the end that you recommend these vaccinations. Flu shot, COVID booster, RSV, and pneumococcal. They'll take care of shingles and Tdap. Pharmacy will give the flu shot and COVID booster, but if you mention it, they'll pay attention. Patients will too. This is the last slide. I'm going to keep this on. We have 31 guests remaining. Happy to stay on and answer questions. Happy for you to put questions in the chat as well if you don't want to come off mic. What I will do is I will take a combination of 10 or 15 slides and send it to Megan to distribute to the department so that all of you have a reference deck with respect to some of the key slides on RSV and its impact of morbidity and mortality, the 2 vaccines and the efficacy outcomes, and this component as well onto key nuts and bolts of how we can prescribe this for patients in the Scarborough Health Network via EPIC, and also changes to our practice to have this discussion in the office. 5 minutes remaining, I'll stay off. Otherwise, I'll give you 5 minutes of your life back. Look forward to COPD as well as biologics in the setting of asthma in the new year, COPD in January, and biologics in March. Have a wonderful Wednesday, everyone. One more thing, colleagues, attendance and evaluation form are in the invite as well as in the chat, so please do fill it out. Thank you.
Hello, Sasha. Can you hear me?
I can, yes.
Hi, it's Jung. Great talk. Thank you very much. I think this is very important for us who practice in the office to advocate for patients. So practically speaking, between the RSV and the new vaccine, like how are you going to write that order? Like
So practically speaking, this is what I have on this slide. This is the excerpt that I have from my EMR. So my EMR, I have Oscar and Acuro. I searched for a RexV. It is in the database. I added it as a favorite.
Right.
Yeah.
The question is with between that and the other one.
Between the two. Yeah.
Brisbane,
yeah.
Right? Like
so
how do you specify? I mean, do you need to, or can you, or can
so
you let them
the
decide?
short answer is yes, you do. And when we look at 3 aspects of efficacy between a RexV and a Brisvo, the fact that we have 3-year data with a RexV, and at the most we will have 2-year data with a Brisvo, I have more confidence in a RexV with respect to the duration of action. There's a greater percentage efficacy with respect to percent reduction. And also a RexV is the only vaccine that has severe RSV infection reduction data compared to a Brisvo. So if you write RSV vaccine, you'll get a question mark back from the pharmacist. You do need to specify. My preference from a patient perspective, and the advice that I've given to my father, my in-laws, and relatives is a RexV for those 3 reasons. I want to prevent severe hospitalized infection. It has 94% efficacy for that. I want a longer duration of action I have at least 3 years data with RSV. I will probably have 5 years data at the end of the clinical trial, and I have a similar safety profile. So
No,
all of that
yeah,
makes sense.
thanks. I think you were very clear with that during your presentation. I guess my question is like, how do you avoid going back and forth with the pharmacy? Are you going to give them both prescription and say, get whatever you can afford?
No.
Because you prescribe a RSV, they're going to come back and say, okay, it's not covered. I want the other one. Like, how does that?
So
That's what I'm.
so if you have an outpatient over the age of 60, unless they live in long-term care or a retirement home or elder care lodge, it's not covered. Private insurers will cover a RSV and a Brisvo, but for the lion's share of patients, they're paying for this out of pocket. The out-of-pocket cost is the same. So I have not had issues with pharmacy coming back to me with respect to a RSV versus a Brisvo. I do disclose to patients the cost of the vaccine in the office, but for those with an insured indication from the government, it is really only those who are hospitalized.
Okay.
So not something that we're going to encounter in the office. And if they have private insurance for vaccine, so if Shingrix was covered for them, for example, a RSV and a Brisvo are covered by those private insurer plans, but every insurance plan is different.
Okay, so that's helpful. So super practically speaking, I have a
Yeah.
RSV already in my EMR. I don't have to add a Brisvo because we think that a RSV is better. So we're just gonna leave it at that. Yes?
Correct. Yes.
Okay, thanks.
Yes.
Okay,
No
so it's very
worries.
simple. Thank you.
Yeah. All right, folks. 12:59. Have yourselves a wonderful day.